Welcome to our live webcast, Diagnostic Imaging in Pain Medicine, When to Order and How to Read. Thank you for joining us tonight. This webcast is supported by Azra Pain Medicine and also by the APPD, the Association for the Pain Program Directors. My name is Rene Przkora. I'm the Program Director of the Pain Medicine Fellowship Program at the University of Florida. Our home is Gainesville in Florida, and I'm proud to be joined by our speakers, Dr. Syed Wahezi. He's the Program Director of the Multidisciplinary Pain Medicine Fellowship at Montefiore in New York, and then Dr. Amir Jafari and Dr. Matthew Meroney, colleagues of my division here at UF in Gainesville. A few technical items up front. We will be happy to answer any questions the audience might have. We'll try to do it live, but we'll do it at the end of all three presentations. So they will start roughly around 8 p.m. And please use the Q&A icon at the bottom of your screen to write down your questions. Either you can provide your name anonymously, however you feel comfortable, and we will address those questions at the end of all three presentations. And we'll start the evening with Dr. Wahezi from New York. And I think the screen is all yours.
Thanks, Rene. Listen, I want to echo Rene's sentiments about the importance that Astra plays in what we're doing and how we're educating our learners. They're an integral part of what we do, really on an almost daily basis. So I think Astra and I appreciate the help of my colleagues who are on the webinar with us today, and certainly I appreciate everybody who has signed in and is continuing to sign in as we're speaking. There's a lot of information that we're going to be going over tonight, and really I'm going to try to educate based upon some cases that have come through my practice, as well as a publication that both Rene and I have been a part of in the course of the last year or so. Okay, so I'm going to share my screen with the team here. Okay. Rene, can you see my screen? I'm going to use you.
I can see your screen. You make and hit slideshow.
You got it. Let me just maximize this. I'm going to hit the slides. All right. And I think we're all set. Is that correct? Okay, fantastic. You know, over the course of the last, I don't know, 2 or 3 years, you know, I have been really I've become more of an advocate for understanding what we're doing today, meaning educating our learners, educating our young learners, as well as our more advanced learners on imaging. We have become a specialty based on procedures, based around procedures, and procedures have become the cornerstone for how we make assessments, because they've become diagnostic, but certainly also therapeutic as well. The importance of keeping these procedures around is understanding when to do them and when to do them correctly. And so the hope is that, you know, through the presentation today, that everyone on the webinar has an understanding, or at least has a little bit of a better understanding of what they're looking at and why they're ordering the things that they're ordering. Okay, and understand that this is just the tip of the iceberg. Everything that you're going to learn about today is really important, but we are just beginning the conversation. And you'll see in a few slides from now, probably about 5-10 minutes from now, you know, how intricate and complex reading some of these images can be. And when you consider what we're reading around the complexity of the patient population that we deal with, right? A lot of patients who come in with diagnoses rather that we're not sure of, or, you know, the referring providers are sending to us because they've seen other specialists, and they're not sure. So we are really supposed to be evaluating MRIs, CTs, ultrasounds, X-rays with a very fine eye, and sometimes with a microscope, literally. Okay, and we'll see that momentarily. Okay, so I mentioned, we're going to discuss case presentation, and this is going to be really basics, but there's a lot more to this. My hope is that we whet your palates tonight, and that everyone on this call becomes even more enthused about what they listen to and about what they see, and you want to learn more. And please give us feedback as to how we're doing and how we can make this better to elevate this kind of educational session to the points where I think that we really need to go to get our field to grow. All right, so these are my disclosures. I am a consultant for Boston Scientific, and I do have research grants from these 3 companies. All right, so MRI. The foundations of MRI are, I think I'm going to keep it pretty simple. What MRI does is it creates a magnetic field around selectively polarized molecules. Fat is polar, modestly polar. Water is one of the most polar molecules in our bodies, and what it does is it creates a conformational change, a spin change of the hydrogen ions, and then that allows an observer to be able to see differences in tissue types. It also, based upon different sequences, creates vacillation of larger and smaller molecules. And then by mathematical modeling, what happens is you're able to see different densities in different shades of gray. Okay, and that's really what allows us to see the things that we need to see on an MRI. Again, this in itself is an hour lecture, but I'm going to leave it at that for now. Understand that there are different sequences in an MRI: proton density, T1, T2, stir images, okay, fat suppression, which are similar to stir. But what we see is different in each one of those sequences with respect to the tissue types that we are evaluating, okay, and the different compounds that make up those tissues. All right, CT. Essentially, CT is an X-ray or multiple X-rays that are shot almost continuously. They're shot at about a fraction, about a millisecond apart. And for those of you who have seen an X-ray, and I think most of you have, our patients go into a donut looking like structure, and then on one part of this donut there is an element that just goes around, and for every millisecond that this mobile arm rotates, it's taking an X-ray. All right, and then a computer assesses each one of those points, each one of those pictures, and by a matrix or mathematical computational, which evaluates different equations simultaneously, it creates an axial image. Okay, and that's how we come to know, the 3-dimensionality which a CT scan is supposed to convey. All right, you may hear me during the course of tonight's lecture mention Hounsfield units. Hounsfield units are what radiologists use as determining factors in tissue type. All right, these are grayscales which are defined to create an understanding of a tissue type, i.e., the baseline of water. Okay, and this is just this is just H2O, no normal saline. All right, but just water. Baseline of 0 Hounsfield units. I'll say, okay, so the Hounsfield units are calibrated based on water. CSF, muscle, gray matter of the brain, white matter of the brain, and other tissues have different Hounsfield units, and these become brighter as they become positive, and they become less gray, they become darker, the darkest being air, as you go into the negative digits, okay? So again, just baseline framework, right? I was asked to talk about central canal stenosis. Central canal stenosis has become a very important diagnosis that we see, and sometimes don't see, and sometimes see but it's not really there. And you'll know what I mean momentarily. But central canal stenosis is a pathology whereby a central canal or a neuroforamen, for the next couple of slides, we're going to be talking about a central canal, and this is lumbar, okay? Because you can talk about it in the thorax as well, you can talk about it in the cervical spine as well, but I'm dedicating this particular lecture to the lumbar region. So I want you to understand that this is a vertebral body, okay? This is a vertebral body. This out here is disc, and we'll talk about why you can have actually a vertebral body and a disc on one image momentarily. But here's a vertebral body, here's the central canal, here's the SAP, here's the IAP. And again, this is on axial section. And what we find is this area here is where the cauda equina live, right? These are the fibers, the terminal fibers that come off of the conus medullaris that then stream down and become L1, L2, L3, L4, all the way down to S4, okay? So depending upon what level you are, you're going to have a different number, a different density of nerves in this space. The lower you go, the lower the number of nerves and the greater freedom these nerves are supposed to have. But one thing that can happen as a spine becomes degenerative over time is that this space starts to become smaller. How does it become smaller? Well, it can become smaller. It can be small, rather, because pedicles are short. And these we find primarily in large, this way, and tall adult males. Okay? Why? I'm not sure of the genetics behind it, but this is something that we commonly see. In the pediatric population, I actually see this in some genetic patients who have some genetic pathology as well. Patients who have Down syndrome tend to have this a little bit more than patients who don't. All right, this is just an observation that has been documented as well. So short pedicles can make this canal smaller. Ligamentum flavum, which I have not hypertrophied much here, but it can become hypertrophied even more over time. Why does it become hypertrophied? Well, we don't know if it actually becomes hypertrophied or if it just buckles because of degenerative disease. But just understand that when we look at these images on axial, from an axial view, this can create less space back here posteriorly, which then forces the elements anteriorly. Again, forces the elements anteriorly. We see ligamentum flavum over here, SAPs, IAPs, and we mentioned here vertebral body and disc that outlines here. Okay. Facets, by the way, also a culprit. So facets can actually get larger as well. Now, when they get really big, we usually find this in L5S1, L4, L5, and sometimes L3, L4, where these SAPs become so large that they actually start to infringe upon the lateral recess right over here and the lateral recess over here. We kind of see it happening here, where these SAPs actually get larger. This kind of looks like an L3-4 level, but these facets get larger, and then you start to get a lateral recess stenosis here, okay? But albeit this is a central canal stenosis, and these are the reasons for it, okay? Oftentimes seen on an MRI, best seen on an MRI. This appears like it's a CT myelography, okay? You can also have it, it's not something that we commonly talk about, but with disc bulges. And usually it's with circumferential disc bulges. One of my colleagues tonight is going to be talking about disc herniations, and I think that there may be a short discussion about how a bulge is different from a herniation. But here I'm just going to present to you the idea that if a person has short pedicles, a flavum that's buckled or hypertrophied, an SAP that's large, and or a circumferential disc bulge, this narrows the space here. So you have a mechanical compromise of the stuff that lives inside, right? Those cauda equina that we talked about. And that can present as pain. How are we taught to teach this? Well, patients can have pain with standing. They can have pain with walking, and the pain improves with sitting or lying down. Now, an element that we're not taught to discuss really, but I think it's really important, is to ask our patients how long they can stand for or how long they can walk for. If a patient comes to me and they say, Doc, you know what? I have pain with standing and sitting. And then I ask them how long. And they say, you know, I can't walk for more than 6 miles and I can't stand for more than an hour and a half. Well, at that point in time, I know that, you know, the interventions that I have in my back pocket may not help. On the other hand, if a patient tells me that they have difficulty with standing or walking for more than 5 to 10 minutes, and that they can't, or standing or walking for more than 5 to 10 minutes, at that point in time, I know that I may have something up my sleeve to be able to improve upon, you know, their walking and standing tolerance. Okay, so us as practitioners have to know our limitations as well. So I ask the learners tonight to just please request from your patients that other bit of information. How long? Okay, because it can change how you treat, how you assess, and then how you treat your patients. Okay, you know, acquired lumbar. Let me just get my Zoom bar out of the way. Acquired lumbar stenosis. I think we talked about this. You know, I gave you, you know, diagrams and some degree of animation as to really what I wanted to chat about now. And so I'm going to go to the next slide because I think everyone gets the point. You know, I'm just restating the points here. Large facets down on the bottom, ligamentum flavum hypertrophied up at top. Okay, a disc bulge. Okay, all of those things can narrow the canal. Pathodynamics. What do I mean by this? I kind of coined this term. Essentially, what I mean is pathology that occurs over time, right? And this is really supposed to be the explanation for degenerative, in this case, central canal stenosis, but you can also deliver this conversation to talk about facet arthropathy as well. So what do we think happens? Well, based on Kirkcaldy-Willis, who described these elements in 1988, which there's still some belief that things from 1988 are still real and important. The degenerative discs, okay, discs start the compromise by becoming dehydrated. Once they become dehydrated, these end plates start to come closer. Once the end plates start to come closer, the facets posteriorly start to come closer together as well. And in meaning they start to axially load. Once they start to axially load, the next element of hypertrophy is the SAP hypertrophy, where they start to then grow into the central canal, creating either lateral recess stenosis or a true neuroforaminal stenosis. And that's when people start to have, you know, their back and their leg pain. Okay, so this is, you know, how we believe that this starts. As it becomes a little bit more advanced, you can actually start to see OA and or modic changes, which one of our colleagues will speak about tonight as well. And I'll leave that up to a conversation later. All right. And here I'm just creating arrows as to, you know, the pressure points that then create change over time. All right. And this is what we just discussed, meaning axial loading here, then posteriorly, and then the facets start to hypertrophy. Okay. And this can cause axial pain, but this can actually enlarge and cause neuroforaminal entrapment and central canal pathology as well. All right. This is kind of hitting the point as well. Here, you know, I'm showing a diagram with regards to disc herniation versus bulging. I'm going to go through this now because someone else will be speaking about it later. CT scans and central canal stenosis. So one thing that I want everyone to understand is that if a patient cannot have an MRI, the next best thing to be able to evaluate central canal stenosis is a CT scan with an injection of contrast within the central canal. And sometimes this can actually be even better than an MRI. Why? Because an MRI demonstrates a volume occupying pathology, but it doesn't really give you a lot of information about pressure and how much pressure there is in a space. So if one looks inside this level here, which seems to be L2-3, you can see just a little bit of contrast that's built up inside of this inside of the spinal canal. But at L4-5 and at L5S1, you start to see more. Okay, that means that of the 3 places where this patient, and I'll tell you, this patient demonstrated canal stenosis on an MRI, it appears like the greatest mechanical and volume limiting. So we are creating an analog of pressure with respect to the volume of contrast that's occupying this space. So if you go by that, L2, L3 is the area where the greatest mechanical compromise is. Okay, so one can use a CT myelogram in isolation or to improve upon the understanding of an MRI, especially if a patient has multiple levels of stenosis. Okay. Paraspinal atrophy. Guess what? I put this in here because this is important to the conversation of central canal stenosis. Why? Because what did we mention was the important historical findings in central canal stenosis? Difficulty with standing, difficulty with walking, right? Pain improves when you sit, pain improves when you lie down. Well, why is that applicable here? Well, because patients who have paraspinal atrophy, they don't have muscles that are able to carry a person in an anti-gravity fashion for several minutes, all right? Depending upon the degree of stenosis, maybe even several seconds. So a patient who has paraspinal atrophy can actually have the exact same complaints that a patient with central canal stenosis does. Pain with standing, pain with walking, okay? When you take a look at these MRIs, and MRIs are really the way to go with this, but when you take a look at the MRIs, an MRI will be able to demonstrate the fatty contribution that has replaced what used to be muscle, okay? This is your psoas muscle. These usually do not degrade, okay? This is your multifidus. This is your multifidus. This is erector spinae. This is erector spinae. Look at the color differential between here and here. This person came in with the exact same complaints as a person with central canal stenosis. Look at the MRI. Does this person have any central canal stenosis? I'm hoping that of the 99 people who are on this call, 99 said no. Okay, but I think it's pretty clear that this person has fairly severe atrophy. The treatment for that, well, that's not part of this discussion, but again, that could be a lecture in itself. I want to point your attention to a CT scan, which demonstrates fat streaking. The Hounsfield units within this muscle is different from the psoas. This, by the way, is the same patient. Okay, so if you take a look at these muscles here, okay, nice and gray. And if you remember the Hounsfield units for muscle, they were in the positive numbers, right? In the very positive numbers, fat was less. Okay, and so the fatty contribution and the fat streaking, those of you who remember internal medicine, and we talked about, patients who had fat streaking when they had pyelonephritis, it's a similar idea. The Hounsfield units are less in general in totem than in the psoas muscle. So it's a clue. And for those patients who can have an MRI, if you've sent for a CT, or if you're looking at a CT abdomen and pelvis, and you happen to see this, and you want a better look, please obtain an MRI, okay? Because it'll give you, a better understanding of what's going on. It may give you a better understanding as long as you know what you're looking at. This patient here has selective multifidi atrophy. Why? I'm not sure. This person did not have a radio frequency. For those who are one step ahead of me, and ahead of some of the others on this call, radiofrequency ablations ablate the medial branches, and the medial branches provide motor information to the multifidi, right? So one would think that if you denervate the multifidi by doing radiofrequency, this is what you get. Well, this person never had a radiofrequency, but this person has selective atrophy of the multifidi. Okay, so this may be some subtype of a spinal muscular atrophy. All right. Heterotopic ossification. Well, in light of the fact that we're talking about these paraspinals, I figure I'd share this picture with you as well. This is a patient who has pain with walking and standing after a lumbar fusion. Now, I'm not showing you the 3-level lumbar fusion that this person had, but I do want to show you, okay, at this upper level, although here you see some rods here, and here you see a pedicle screw. You see heterotopic ossification of the multifidi, which can occur. And this is not bone marrow protein that the physicians put down around the heads of the screws. This is ossification, calcification of the muscles within the paraspinals. This is a really tricky thing to treat, okay? Spinal cord stimulation was the only thing that I could think of that could help this patient, because they can't be operated on. And if they do, and if they are operated on again, this will probably happen at the next levels that they get their surgery. So this was unfortunate for this person, but it was a diagnosis that that was aided by a CT scan, not an MRI. Why not an MRI? Because on an MRI, muscle is black. Okay, and these osseous points would be black. I pause because I'm hoping that people are saying this before I say it. Okay, so on a CT scan, different look. Okay, neuroforaminal stenosis. What I want people to understand from the next several slides is that patient positioning, patient curvature, and the grade of axial and coronal cuts make an enormous difference in how we understand neuroforaminal stenosis, okay? The neural foramen in a normal patient is about 1 to 1.5 centimeters in height, okay? And about 1 centimeter in depth or width, meaning going lateral to medial. That means that a cut has to be almost perfect, okay? Even in a patient who doesn't have these confounding variables here, in order for us to see neural foramen. An axial is not good enough, okay? I will rest on that laurel, and I'll just mention to you that Rene and I published this paper last year illustrating that, okay? And we had some patients that we put in an MRI. I was one of those people who went in an MRI. We curved our bodies. We were straight spines for the most part, curved our bodies. We mimicked scoliosis, and then we had our radiology technicians, our MRI technicians, take different cuts at different angles. And what we noticed was, if you don't take an angle perfectly down the line of these pedicles, and the pedicles have a natural obliquity, if you don't take it down these lines, then our evaluation, our relative evaluation of these neuroforamina are off. Okay, I'll leave it at that. When you have a patient who has a curvature, it becomes even more difficult to assess the relative size of these foramen. Okay, here the gantry of the axial sections makes a difference. Okay, as to whether or not a person has true or false stenosis. All right. So if the MRI technician's having a bad day, all right, and if they didn't have a V8, for those of you who are old enough to actually understand what that V8 reference means, when the radiology technician is kind of sitting like this and they cut everything on an angle, well, that's going to inhibit or mitigate our ability to be able to determine whether a patient has true or false neuroforaminal stenosis. Okay, and we outline all of that in the manuscript, and we give you a guide for that as well. Epidural abscess. This is a patient who was a patient of mine who I put in a spinal cord stimulator in. 3 days after the spinal cord stimulator, the patient came in looking very toxic, no fever, but this person had more back pain than what they did before. And this was not just the post-procedure pain that some of our patients, about 20% of our patients, complain about with spinal cord stimulation. This was a patient who walked into the room who felt almost nauseous because of her pain, okay? I pulled the leads. She had pain even in the areas where I put my my plastic anchors. I anchor my leads to the skin on trials. And I sent her to the ED. The ED did an analysis, and what we found was that this patient had, well, an epidural abscess and a phlegmon right over here. Okay. We followed her after a couple of days, and what we actually saw was that the phlegmon got larger. Neurosurgery wasn't really concerned. She had no neurological deficits. Her pain started to improve. She did not have a fever, and basically she was just sent home on PO antibiotics. Okay. This is another patient who had an epidural abscess. Okay. But this patient had a history of a laminectomy. This person presented with a similar toxic look about a month and a half after the development of the abscess. Why was the before and after important? Meaning, why was the slide before important and this one important as well to talk about in sequence? Well, the last one that I showed you did not have a laminectomy, which meant that the pressure in the spine built very quickly. This patient had a similar size abscess, but they had a little pocket where the laminectomy was that allowed for a stress relief point. And this patient actually built their symptoms slowly. Okay. So consider that when you are evaluating patients. You know, if a patient has a laminectomy or has a previous surgery, they can actually present to your office in a more toxic way, but over a longer period of time. Okay. This is an important element for all of us because it can determine failure or success from assessing and treating patients who have back pain, and treating patients even who have a canal stenosis with some of the minimally invasive surgical tools that we have. All right, with the surgical tools that we have, when we published the MIST guidelines, the minimally invasive spinal treatment guidelines, part 1 and part 2, 2 years ago and 4 years ago, one of the things we mentioned was if a patient has a dynamic listhesis, some of our tools are going to fail. Okay, both indirect and direct decompression. Well, making an assessment of dynamic instability is really important, and sometimes it's very subtle. All right. In this patient, we have someone who comes in with back pain. Okay, axial pain when they sit down. We see this Tarlov cyst. I look at Tarlov cyst and I just go like this to the patient and I say, well, I'm not exactly sure why you have your pain, because almost everything that we read says the Tarlov cyst shouldn't cause you pain unless it's large enough to actually be eroding through your entire sacrum. This is not that large. Okay, this is a medium-sized Tarlov cyst. When I looked at the MRI, however, I saw that when this person was in the MRI, and this was an MRI where a patient was laying supine, we saw a significant amount of fluid within L4, L5, within the L4, L5 facets. This was a moment for me. Why? Well, there are studies that demonstrate that if there is more than 2 to 3 millimeters of fluid streaking inside of a facet, and there's people who actually believe that even 1 millimeter is important. I think that 1 millimeter can actually be physiologic in some facets, but if you see this much fluid, okay, may not be a bad idea to get a flexion extension x-ray. And on this flexion extension, I just want you to take a look at this versus this. On this supine MRI, this person has 0 listhesis. On this x-ray where the patient is just standing, this is not even a flexion. I don't think this is a flexion, but when they're standing, there is a grade 1 listhesis. So there's a dynamic listhesis here. So if we're thinking about doing a medial branch block / radiofrequency ablation, it's going to fail. If this person did have stenosis and they don't, and we decided to do one of our minimally invasive surgical procedures, it would have failed. Okay, unless this person has effusion, this person's back pain may not go away. All right. And so I just want everyone on this call to understand the importance of being able to interpret an MRI and an X-ray, not in solidarity, but in sequence. Okay. If you learn nothing from tonight, I want you to understand that. Okay. Other things that can cause back pain and leg pain. Guess what? A uterine leiomyoma on this patient who has left-sided back pain, leg pain, and was pain and had reproduction of their pain when I palpated in the lower left quadrant. Okay, so be on the lookout for those as well. This can hide out on lumbar spine CT scans and on MRIs. Why is an MRI, why is a CT scan important? Well, I already told you there are certain things, calcific aspects that you can see on a CT scan that an MRI won't necessarily show you. This is a patient who has ankylosing spondylitis that went undetected for about 40 years. That's 40 years, okay, until we looked. This is an MRI of a patient that a surgeon actually used to do an operation because this person had had pathology that they thought was, that the surgeons thought was causing the patient's back pain up here, okay? When we did a CT scan later on, based upon an X-ray that my team and I looked at, what we saw was that the X-ray looked a little squirrely. We couldn't really see an interlaminar space. So we sent this patient for a CT scan to determine then that the entire spinous process elements were fused, okay? Thorax to lumbar. All right. So there wasn't a surgery that was going to help this patient. Okay. Luckily, this patient auto-fused in a straight position because sometimes these patients actually end up being almost 90 degrees by the time they're 20 or 30 years old. All right. And I think I'm almost done. Understand that there's other reasons for having back pain as well. This is a patient who has chemotherapy, i.e. lupulloid myositis, where you can actually see an iliopsoas hyperintensity on MRI. Okay, cannot really see it on a CT scan, but shows up here on an MRI. Okay, again, there are certain chemotoxins that can cause a myositis, and some of these things happen in weird places that can cause back pain. All right, I'm done, everybody, and I hope you enjoyed the show.
Thank you very much. This was an excellent presentation. And I, of course, do agree with you. And that's the reason we're having this as the start of the academic year, you know, that we as pain physicians and hopefully some of the audience are going to be the future leaders, you know, that we look professional, that we can explain why are we ordering our imaging scans, what are we specifically looking for. You know, when we talk to our radiology colleagues and also to our referring sources, and also, let's be fair, for our surgical colleagues, you know, that are we using basically the same terms when we describe pathology, and that gives us credibility and will hopefully use the correct tools to help our. I think let's move on.
Okay, Dr. Jafari, you are up next, please.
Hello, good evening. Can you see my slides okay?
We can, we may need Dr. Wahezi to stop sharing.
Okay.
Probably, yes. You got it. Thanks, Michelle.
No problem.
Let me get out of here. I thought I stopped sharing. I apologize, everybody.
No problem. And we also heard the voice from Michelle. She is our support from Azra Pain Medicine.
I think that my slides are up now. Is it showing up okay?
Looks good to me.
All right. Thank you, Dr. Wahezi. It's actually interesting because I did have a case where one of my patients' lumbar radicular pain completely resolved after a hysterectomy from a fibroid mass. So it was so large that it was actually pushing posteriorly under the vertebral body and causing the compression. All right. So I have 15 minutes to go over these topics shortly. Just a quick recap of basics of MRI. Again, as a reminder, fat is bright on T1 and dark on T2. CSF is bright on T2 and dark on T1. And spinal cord is showing up dark on T1 and T2. STIR stands for short tout inversion recovery. This is the image that we use, especially if we're evaluating patient for kyphoplasty. to see if there is edema in the end plates or there's fluid collection. And also, when you obtain a contrast imaging to look for abscess or things in that nature, you want to compare the T1 with and without contrast. All right, so one of the pathologies that it's been a hot topic now because of especially because of the new procedures coming out for it, is Modic changes. Now, Modic changes are signal changes in the vertebral end plate and bone marrow. This is usually happens when there's bone marrow edema, fatty degeneration, and osteosclerosis in the end plates of vertebral body. Now, what can cause these Modic changes? Disc herniation, degeneration in the disc, end plate defects, patients who smoke for many years, older age, spinal deformities caused by, for example, severe kyphosis or scoliosis, or even genetics. Now, these are mostly inflammatory changes. I call it an inflammatory soup at the end of that end plate that basically changes the shape of the bone. These vertebral bodies are highly innervated. They got a lot of nerves in it, and these nerves can become very painful when there's a lot of edema in these vertebral bodies, and they have become a target of ablation now, specifically with the Intercept procedure. Now, some of these patients, when they get this edema in the end plates, because of Modic changes, the pain can go away over time if you treat them conservatively. Now, type 1 Modic change, and this is the way I memorize it, is type 1 only lights up on one, which is T2. Type 2 lights up on both T1 and T2, and type 3 doesn't light up on any of them. So it's dark on T1 and T2. Here are some examples. Type 1 only lights up on one of them, which is T2. And you could see that when I say lights up, it means it's bright on T2 and it's dark on T1. This is an example of type 2 Modic change, which is bright on T1 and bright on T2. And here you could see that the end plates are not smooth lined. These are jaggedy lined. There is inflammation going on here. The bone is eroded. Some of the disc material has entered the end plate, and that can be the cause of inflammation in there. And this is an example of type 3, where the type 1 and type 2 has already occurred, and there's scarring down here, and now it's dark on both T1 and T2, and osteosclerosis has happened already. And when you talk about an Intercept procedure, usually it's indicated for type 1 and type 2, but not type 3 end plate changes. Now, these patients with these end plate changes, it's very hard to diagnose end plate changes as a pain generator. It's very difficult. So usually we get to this point looking at these end plate changes when all of our other procedures have failed. So we're slowly learning how to pick these out. One of the things patients complain of is pain when they're getting up from a seated position. And we're starting to call these anterior column pain. Next pathology would be vertebral compression fracture. This has become a common pathology, especially as we have an aging population, a lot of osteoporotic patients. Now, if the fracture happens acutely, let's say an osteoporotic patient has a car accident or has a fall and they have a major fracture, it can be very painful. However, if the fracture develops slowly over time due to osteoporosis, then these patients are usually asymptomatic. Their pain, in acute fracture even, their pain can be tolerable, or it can be incapacitating, where they have to be admitted to the hospital. Very large variability in their presentation. Now, during your physical exam, you'll notice these patients will have tenderness when you push on the spinous process of the level that has the compression fracture. They will have severe tenderness in that area, and also the paravertebral area structure as well. Some of these patients will have pain radiating out towards the anterior chest wall or towards the abdomen. Sometimes it even radiates down towards the extremities if there is a pretty severe retropulsion. What is a retropulsion? And this is when retropulsion happens when a portion of the end plate or the disc or whatever is fractured is pushing back posteriorly into the spinal canal. That's basically either compressing the main nerve, the central canal, or the nerves that are coming off the main nerve, the roots. Usually these acute pain usually resolves with 4 to 6 weeks. If you give it time, usually we give it 4 to 6 weeks, conservative therapy, we use bracing, NSAIDs, over-the-counter medications, sometimes tramadol, and see how they do. They need to rest and let it heal. Calcitonin is another treatment that's also offered to help increase the bone density, and it's very helpful with pain. But some patients don't recover after 4 to 6 weeks, and that's when we consider them for the kyphoplasty procedure. Now, every time there's a complete compression fracture of a vertebral body, the patient will lose approximately 1 centimeter in height. And 4 centimeter in height loss can cause about 15 degrees in kyphosis. When you have kyphosis that's severe, that can affect the entire physiology of the spine and cause changes, anatomic changes in the adjacent segments, adjacent levels. This can lead to adjacent segment disease, facet dysfunction, or even compression fracture in the neighboring section. Now, the cause of a compression fracture is osteoporosis. I think it's over 80% of it. Now, the differential diagnosis of that you think of would be hyperparathyroidism, hematologic diseases, anything that can cause these vertebral bodies to get soft or break down. Infection, metastatic disease. Patients with prostate cancer can metastasize to these vertebral bodies, osteomalacia. Now, I will show you in another slide how to grade these vertebral bodies, height loss, but grade where it's graded. And sometimes the insurance companies look at grading as well before they approve it for a major procedure like kyphoplasty. But grade 1 would be 20 to 25% height loss. This is the area that's lost its height the most compared to the area that has no height loss. And grade 2 would be 25 to 40%, and grade 3 is greater than 40%. And as I went over it previously, some of the treatment options would be bracing for acute, subacute fracture. Obviously, if it's a chronic healed fracture, bracing is not going to do anything, and you're just going to make the patient immobile and make them become have more atrophy and get weaker. So I want to be careful with that. Oral analgesic like acetaminophen, NSAIDs, tramadol, calcitonin, and kyphoplasty. Now, this is the grading picture. You could see that grade 3 is the worst one, more than 40%. And these are the different types of fractures. The wedge fracture is the most common one I see. Usually it's the one that wedges down anteriorly in both superior and inferior end plate. The biconcave fracture, you'll see it caving in right in the middle. And this one, with the kyphoplasty, try to get the balloon right in the center, trying to expand this area. And the crush fracture is when the collapse happens to the posterior portion of it. This is an example of a severe wedge fracture, and you could see that 12 days later, this patient has developed adjacent segment disease, where another level fractured. Even right here as well, you see the whole structure just changes. Now, this is a good example of why it's important to have a CT and an MRI, because as you can see, this patient has a pretty severe compression fracture where there is retropulsion. If you just had the MRI, you would think, okay, which one is disc, which one is the bone? But here you could see the bone sticking out, as well as how much compression of the central canal is happening here. The nerve roots are being compressed completely posteriorly. This is an X-ray. This is a CT. And this is the MRI of the same patient. All right. Another pathology to watch out for would be multiple myeloma. This is a multifocal malignant proliferation of the monoclonal plasma cells in the bone marrow. Usually these patients present with high calcium levels, marrow failure, anemia, infection. They can have low white counts. They complain of generalized bone pain. And obviously, if you detect this, you consult the appropriate service to take care of these patients. But treatment would be supportive analgesia, bisphosphonate, which basically, if you remember osteoclasts in the bones, which break down bone and release calcium, what's an inhibitor of the osteoclast. Erythropoietin is used to help with the increase, to improve anemia, and local radiation, chemotherapy, bone marrow transplant. These are all options for these patients. This one, multiple myeloma, is pretty tough to, to diagnose on imaging, but this is what you'll see, some generalized, just scattered brightness. And I have another picture that would be our T2. You could see that this brightness is just everywhere. Like if you would think that, okay, this could be a hemangioma. Usually hemangiomas, you don't see multiple of them everywhere and a bit larger, but they're also bright hemangiomas. They are, they have defined borders, but they're much more bright on T1. They're not dark like this. This is another example of multiple myeloma, very large, space occupying. This patient can end up getting a compression fracture. All right, DISH. DISH stands for diffuse idiopathic skeletal hyperosteosis. This usually happens in the anterior vertebral ossification, the front of the vertebral body, and this can lead to difficulty with swallowing. Usually happens in the upper spine. As you can see, that this is the anterior portion of it, and you need 4 adjacent segments to be involved for it to be diagnosed as DISH. And you can see that esophagus is right in front of it. So this patient is going to have a difficult time swallowing. And it definitely, this autofusion that it creates limits the mobility, the natural motion of the spine. And that can, affect all the structures posteriorly and cause degeneration. So it's not just this area you worry about. Now, these patients, treatments usually, you don't conservatively, majority of the cases are conservative treatment, but sometimes they will have to have surgical resection of it. Especially I've seen patients who have a true dysphagia where they can't swallow food. So ossification of posterior longitudinal ligament is another one of these pathologies that's caused by calcification. This one is the PLL that's calcified. The posterior longitudinal ligament is the ligament that's sitting right on the posterior part of the vertebral body. And you actually can see it sometimes light up with the contrast when you're doing a transforaminal epidural steroid injection. And, these patients, they can develop pretty severe central canal or even foraminal stenosis when this calcification occurs. These patients can have myelopathies if they get the severe stenosis. Treatment would be asymptomatic patients with careful observation. Usually these are found incidentally. A lot of times they're, you don't want to, these are going to require extensive surgery. So if you can treat it conservatively, it will be preferred. But symptomatic and high-grade stenosis patients, they would have to have anterior corpectomy or even laminectomy and decompression. This is the posterior longitudinal ligament. This is the normal area right here. But as you go up, you could see that it's getting thicker and thicker. And this would be a good patient to order a CT just to see the actual calcification and the areas that, it will show bone. All right, hemangioma. This is a common benign venous malformation within the vertebral body. Now, these are usually incidental lesions that you see on MRI, and you catch them, for unrelated reasons. In CT, you see well-circumscribed hypodense lesions that will have like a polka dots, white polka dots on the image on the axial CT view. On the MRI, again, circumscribed lesions, and they will have hyperintense they will basically light up on T1 and T2, and it will be like a full circle. And I'll have an example here for you. Here's an example of hemangioma. You could see that's on T1 and T2. It's bright. Usually it's not this scattered. Should have put a better example on here. Usually you'll see a small circle that lights up on both. You want to be careful and try to train your eyes to catch these, because let's say you're doing a kyphoplasty, you want to look for these. You put a trocar in there, you can see quite a bit of bleeding through that, or even doing a intercept procedure. So try to look for these before you schedule patients for these procedures. All right, Dr. Meroney, I'm gonna hand it off to you.
Right, Amir, thank you very much. And I think we're coming to the last speaker for tonight. So folks, please stay on. It's Dr. Meroney from UF in Gainesville. He will also talk about, spinal pathology, epidural, I think traction hematoma, and also about disc pathology. Again, Matthew.
Hey, sir. Can everybody see this appropriately?
Yes,
It
sir.
looks good.
Alrighty. So Matthew Meroney here, University of Florida assistant professor. So the two topics I'm going to discuss will be spinal epidural hematoma and lumbar disc herniation. I have no disclosures. So one of the things I like to always think about whenever evaluating a patient, because they will always be worried about this, is like, when do you need to consider surgery or emergent evaluation? Well, this is what I always talk about. It's red flag symptoms. So new neurologic deficits, specifically, new significant weakness, obviously like progressive numbness, saddle anesthesia, urinary bowel incontinence, those types of things are red flag symptoms that need to be evaluated ASAP. You can't talk about it later. If there's significant, not that we do this frequently, but you probably will in your career. If you're really concerned, you can do a digital rectal exam to evaluate if they have anal sphincter weakness, which sometimes you should. So in regards to hematoma, what are some of the risk factors? The ones that are underlined are probably very significant alcohol use. Patients that had a multi-level surgery, either recently or in the past, and you might have interacted with it, revision surgery. These considerations are more important now more than ever, because interventional pain is becoming more interventional, more surgical, and you may or may not be doing surgical procedures of varying degrees of invasiveness at different levels. Other considerations are calcium levels, obviously abnormal blood coagulation due to varying problems, smoking, hypertension, obesity, and elderly. So smoking is really focused on in the neurosurgical world, and when they are evaluating a patient for fusion, a lot of times the smoking may be the reason they don't offer surgery, because they'll make the patient too high risk, or they may require them to quit. In regards to hematoma, if you were seriously worried about it, that means you were seriously worried about an emergency that can paralyze and or kill someone. So obviously that's the time to get some imaging and try to investigate. Where this is important is when you're doing procedures, injections, surgical interventions, you're going to be in a lot of situations that are gray areas, not so much as a fellow, but when it's you're kind of on the line. These things get a lot more serious. You start wishing you thought about them as a fellow, because I know I did. And the situations are frequently gray, so the situations you need to think about are what just happened. So obviously you'll likely realize that when you're doing injections, patients will note pain that usually can last seconds, minutes, and in some cases injections can cause pain for hours for varying reasons. So that's not an epidural hematoma, obviously, but when you're seeing someone later, or you're on call or something like that, you want to know what just happened. Is this pain that's kind of lingered since the injection? Maybe more related to that just happened. Obviously, if you're doing like a caudal or something like that, and you're doing some hydrodissection, you're doing high volume injections, then you put a big pocket of fluid near a surgical scar that kind of that pressure may linger and cause a pressure, and that would be a little bit less worrisome with that history than just severe pain that you don't know anything about. Obviously, things to consider is when you're when you're placing an injection and you localize that area, you put some local in the epidural space, they're going to have some expected numbness. Well, if you didn't know about that and they have numbness and pain and weakness, you might send them right to the ED. Again, these are situations that might be a little bit less clear when you're on a team, or if you're on call as a fellow or whatnot. So you kind of want to evaluate the situation as a whole, because there are going to be situations where people are going to ask for your advice, and you don't want to just give random advice based off of no information. Let's see, obviously, the patient may not remember these things, so they're getting procedural sedation. So, they're getting benzodiazepines. But there's going to be situations where it is a true hematoma. So statistically, what's more likely? So you're more likely to have something happen, epidural to present within 24 hours of spinal surgery. So again, you're doing mild, different interventions to interact with epidural space. This would be considered that. Usually it's within the first few hours, within the first 6 hours of surgery, but it can present up to 48 hours later if it's just a smoldering, slow bleed. Though I think it's important to realize that if you identify one, not every hematoma needs a surgical decompression. So post-operatively, if you look at neurosurgical procedures, there's, depending what they have, 100% of them, depending on the invasiveness, may have an epidural hematoma. There's bleeding at the surgical site that makes sense. But if it's, an ongoing bleed, it can be due to other problems. So the more common things for us: spinal punctures, obviously OB, epidurals. So about 1/10 of the significant epidural hematomas are from just injections. 1/10 are just idiopathic from we don't know what. So patients that have those risk factors we talked about earlier. Obviously, trauma is a huge component, and which kind of made me chuckle. There have been spinal hematomas just due to chiropractic manipulation. So it's not benign. So things to consider: what imaging are you going to get? Obviously, MRI is the best. MRI is the gold standard. MRI is what's recommended. So real world issues. If you go to I can tell you from experience, if you go to the ER with a patient, because I did, and pretty much go in there and say, I want an emergent MRI. People are going to look at you funny. I'm not saying you can't get it, but I personally sat in an ED for 12 hours trying to get an emergent MRI for a patient that we did a spinal cord stimulator on, because they were endorsing all the signs of epidural hematoma. And the long story short, a CT will show you a big bleed, but it'll miss small bleeds. And if you're really worried about it, you can get a CT that will at least kind of rule out the big, massive bleeds. At least that's something. If you get an MRI quick, great, but I wouldn't wait 12 hours. The patient was neurologically fine in this situation, but you may not be able to get it. So there's kind of a book answer and the real world answer, and that kind of what the radiology department pretty much told me, or what they verbatim told me, was there's no such thing as an emergent MRI, and that might vary on university. So things to think about. So you get an MRI, what are you looking for? Well, it depends on the age of the bleed. Pretty much here's an evolution of how it looks over the first hours to days to weeks. A brand new bleed is going to be hypertense on T2, hypotense on T1, and it evolves depending on the transition from deoxyhemoglobin to methemoglobin to hemosiderin. Here's another reference to show how it looks on CT. CT, it's bright and it kind of gets dark, and then T2 will kind of go from bright to dark to bright, and T1 will go from dark to kind of bright over days and weeks. I can't memorize that, but there is an evolution that will help you at least age a bleed. Obviously, that's useful depending if the patient's had trauma and procedures and injections and whatnot. So you want to know basic anatomy. So pretty much, if there's a bleed in the spinal cord, it's called intramedullary. Let's see, if subarachnoid is kind of from the cord to the dura, kind of where the CSF is. There's subdural bleed that's in the potential space in the subdural area, and then there's some more common epidural bleed outside of the dura that we kind of are a little bit more familiar with. Here's an example of a epidural hematoma posterior to the cord. So you can see on the axial and sagittal compressing the cord. And let's see. This is just talking about the subdural hematomas in the potential space. So here's an example of the spinal subdural hematoma. So it kind of splits that potential space in two. So you can kind of see the epidural space on the outside. You can see the dura on the inside. So all these areas are potential locations. Let's see, on CT, it'll be, again, hypertense. So you can kind of see this, the 50 to 70 HU. HU is kind of the standard measurement on CT. So let's see, I don't know if you can see, you probably can't see my mouse, but it will show bigger ones. It won't show the small ones. So you can kind of see it posterior to the cord there, compressing it a bit. Again, now that we're getting more surgical, depending where you're at, there's certain universities that are very surgical. Here's an example of a post endoscopic surgery of Dr. Jafari's patient that had what we wanted to rule out, or the patient had endoscopic surgery, was doing relatively well, but had all the signs and symptoms of kind of a epidural hematoma, kind of back pain. They were having trouble walking. They really had to flex forward, like they had severe neurogenic claudication that was worse right after the procedure. So we got an MRI to kind of confirm what was going on. And if you look at this just at a glance, the patient looks like they have an epidural hematoma. And if they just went to a random ER, they more than likely would have gotten a emergent laminectomy, decompressive surgery. But when we got the MRI, I specifically talked to the neuroradiologist, because they were initially going to call it as a hematoma, and they were going to help coordinate, I guess, surgical care. And this is why it's important to kind of get involved in all this. And I told him that this patient is post-surgical. They had flow seal injected at this location, and had a discussion. And long story short, that when I told the neuroradiologist that, they were like, "Oh, disregard. This is most likely the flow seal that was injected." And we went from what could have been a hyperreactive situation and emergent surgery to let's just wait and watch. And we'll kind of go over that a little bit. So how do you tell, in this situation, how do you evaluate this? The things that I think that are important to know is that an epidural hematoma, it usually progresses and kind of oozes up and down multiple layers or multiple levels. I would say typically at least 3 vertebral bodies. And as you can see, the area below this, the surgical patient had the majority of what looked like a bleed was at one level. And so and that makes sense, because the flow seal coagulates, it kind of goos up, and it slows down and kind of stays in one area. But bleeding, even though it will do that, it'll kind of progress and widen over multiple levels. It can be many, many levels. So, depending on how far it extends, you might have to get, thoracic or, full spine imaging just to evaluate that. Because the concern would be is that, if you only got one section, there might be the main hematoma could be multiple levels away. So that's something to kind of consider. The majority of these bleeds are 6 vertebral bodies in length. So one of the reasons I was pretty confident in this situation that it was an epidural hematoma is the majority of it, again, was 1 vertebrae. And it's kind of atypical, and we knew we put flow seal there, so that saved this guy's surgery. Long story short, after about 6 weeks, it all dissolved and the patient did great. But it gets kind of scary when it's your patient, So in regards to this topic, in conclusion, you really want to think about the whole picture. What procedure did they have? Did they have sedation? How much was injected? What was injected? And as another example, and this is a situation you may be in, I had a patient that woke up after surgery and was hurting real bad, and the PICU nurses that were not familiar with the patient just saw that she was in a lot of pain and tried to, one of them was, I would say, hyper-reactive, and just emergently kind of approached the patient and family and said that she needed to emergently go to the ER to get evaluated. And I knew the patient beforehand, and I had to kind of gently asked the nurse to stop, I guess, trying to influence the situation, because the patient always looked that way. But she was scaring the patient because she didn't know that the patient was always in a lot of pain, or always was a little dramatic. And we decided not to go to the hospital, and she did fine. All right, in regards to lumbar disc herniation, obviously that's a complicated subject, but just in brief, when should you order imaging? So if there's chronic problems where the pain's not improving, again, new neurologic deficits. So if there's something, if you're planning on surgery or evaluation of surgery, generally the rule of thumb is you want imaging within 6 months, or again, everything's kind of failed and you're trying to rule out diagnosis, maybe for a kind of unusual radicular pattern, and trying to rule out the back or the neck or whatnot. So things, terms that you'll note. So there's bulging disc and herniated disc. So like Dr. Wahezi was saying, there's a difference. So if there's the bulging disc, if that affects over 25% of the circumference of the disc, then that's a bulge. And so the outer area. So if it's if it's bulging everywhere, front, back, left, right, that's a bulge. If it's less than 25%, then it's a herniated disc. So herniated discs are more focal. Bulging is more broad. Again, you'll kind of see here. So as you can see up top, I don't know if you can see my mouse, but you'll see the diffuse bulge is affecting the entire circumference, or the entire outer ring of the disc. And the one to the right of that, it's at least 50%. But if you look at below that, these are not, like the extrusion is not, it's not 25% or more. So it's not a bulge. And extrusion is kind of described by the where it's bulging and the widest diameter. So you can see B is greater than A. So and then the sequestration is where it's actually completely disconnected. These are kind of confusing areas to consider or to understand when you're a fellow. They're really important. So obviously, it's in the center of the canal. It's a central canal zone. So right to the side of that, it's subarticular. Then it's going to be lateral recess, and then foraminal and extraforaminal. And that's incredibly important when you're kind of evaluating what is the effect of a disc. And this is a great picture of why that is. So obviously, if something's foraminal, it's likely going to hit the exiting nerve. But once you start getting more medial, then you could start hitting all these either ipsilateral nerves, or if it's really a significant bulge, it can affect the contralateral nerves as well. Obviously, you combine that with ligamentum flavum hypertrophy and central canal stenosis, you can have every single nerve affected. Which the reason that's important, which I feel like this isn't talked about much, is you can have atypical patterns of pain. So you could have central canal stenosis, and patients can present with no back pain, and specifically pelvic pain. I've had a patient where they were worked up for over a year for pelvic pain urinating, and I happen to see that on their pelvic MRI, you can just see like L4-5 disc, and it looked like it was stenotic, and we got an MRI of that area, and it was severe stenosis. And we did epidural and diagnosed that was it completely resolved after the epidural, and then the patient got surgery. Saved the patient a lot of grief. Here's just some examples of herniation. So if you look at the sagittal on A, you can see at L3-4 is kind of a normal disc. L4-5 looks like there's some type of herniation, and then a bigger one at L5-1. So B, one to the right of that, is a normal disc. C, you can see a protrusion at L4-5, and then a right central extrusion with some migration at L5-S1. So kind of differences. Here you can see a sequestered disc fragment. So that's T2 on the left, T1 in the middle, and then kind of I think a stir sequence on the right of that. And the reason the stir sequence is kind of important is it helps you see that there's some acute inflammatory changes there. And that's kind of helpful, because if you see multiple problems at multiple disc levels, but you see some inflammation at a certain level, that generally means that's probably contributing to their pain. That might be a newer problem. So it helps you kind of maybe focus in on that area because there's some acute inflammatory changes. Here's another example of a patient with left-sided radicular pain, had an L5-S1 disc extrusion. And this is a great example of why we ask patients to wait. From, when you get patients that, they've had radicular pain for a week and they're not, they're not toxic, they don't have any red flag symptoms. This patient, if you look to the left of it, they have a pretty significant L5-S1 disc extrusion. And if it's extruded, then you'll kind of learn about this, that there's some macrophage activity that can kind of eat away at some of the extrusion. And you can see after a few years, the patient's L5-1 disc extrusion actually resolved. And that's not guaranteed, but there is activity that your body will try to do to help the situation. So that's why, this is why I always try to recommend patients to wait on surgery and to see what the trajectory is. If they're kind of getting better, okay, let's see how better you get. Unfortunately for this patient, they had a herniation at L4-5, but I mean, stuff happens. That's my time, and I think we're ready for Dr. Przkora.
All right, folks. Thank you very much for staying on. And we have a few minutes left. And I know there were a lot of topics the speakers have addressed. So I think I see one question here. Okay, two. Let's start. Topic: compression fractures. In the setting of new onset acute disease / fracture of the levels around the initial fracture, would you consider urgent kyphoplasty in an attempt to thwart further degeneration, as opposed to waiting 4 to 6 weeks? Who would like to take that on?
I will. I mean,
All right.
this is depending on who the treating physician is, but I personally would, there's no urgent kyphoplasty. I always, even when I speak to our neurosurgery colleagues, rule of thumb is take it conservatively 4 to 6 weeks, because if you do it and something, you have a complication and they look at it, they always, the first thing they look at is there medical necessity to this procedure? And one of the first things they look at is, did you do conservative treatment first? So a lot of our procedures, surgical procedures, you always want to try to attempt conservative treatment. What if this patient did wear the brace and rested and got all the treatments and this compression fracture healed up and they never needed a kyphoplasty, versus you do the kyphoplasty and God forbid they end up getting a cement embolism or retropulsion. So you follow the not protocol, but the order of treatment, I think is the best way to do it.
My few cents, I do agree to that. We can always say, can it be preventive? On the other hand, if you stabilize one vertebral body in a very osteoporotic spine, there's always a risk. Are you going to get adjacent fractures by that? So I think close, watchful monitoring is appropriate. All right, we're having a few more. All right, next one. What imaging should be ordered in the case where the patient has radicular symptoms but cannot have an MRI, let's say due to a pacer? For example, I get a pacer as a cardiac device, CT myogram, question mark.
I'm happy to take it. I think it's worth mentioning that very frequently, if the patient, the question is why they can't have a pace or an MRI. I would say very frequently the patient thinks that, and then you can ask them for their MRI, the card, the identification card, and a lot of times they can. Or so I would always challenge that, because I would say a third of the time maybe they can. I've had patients that they've had shrapnel and they can get evaluated by the X-ray department, radiology department, to determine if that metal is relevant. If they truly cannot, then yeah, CT myelogram. But obviously, they need to be evaluated for that procedure. Can they get off anticoagulation? In some cases they can't even get that. Then you're kind of left with the CT. But my 2 cents, always question it, and more frequently than you think, you sometimes can.
I'll add to that and just indicate that if a patient has a pacemaker and they have cardiovascular disease, sometimes you'll run into not only the issue of whether or not they can have a CT, an MRI, is whether or not they can even have a myelogram with it, because they may be on anticoagulation, right? And so in those cases, I will tell you that it's important to be able to be a good reader of imaging yourself, right? That's one of the I think, foundational principles that we wanted to convey tonight. Not all CTs are the same, okay? CTs can actually give you more information than MRIs if read properly. And the reason for it is the typical MRI, when it's ordered by radiology, when it's performed by radiology, is done through discs. Okay, so you actually miss a lot of information between the inferior aspect of the pedicle to the inferior end plate on almost every single vertebral body level, because again, the national standard is just to cut through discs, because people still believe that the 1938 publication that demonstrated that disc herniations are the most common reason for back and leg pain still holds true. So because of that, you lose anatomy. All right. Now, the other element of reading CT scans that's important is that when you bring up a CT scan, the reader has the option of being able to look at different windows in the same way that we have different windows to look at for MRI. You know, it's not something that we discussed tonight, but on MRI, it was mentioned that you can evaluate T1, T2, stirs, proton density, and so on and so forth. There's some other sequences that we use for brain and other anatomy, but those are primarily what you use for the spine. But for spine CT evaluation, there are different windows that you can set. You can actually go in, meaning when I look at my CT scans at my institution, I go in and I can actually set the screenplay so that I can look at it from an abdominal CT point of view, which gives me different intra-canal information. I can evaluate it from a bone window that gives me better osseous structure. I can look at it from even a brain window that allows me to see the outline of discs a little bit better. So, when you understand how to manipulate what you're reading, a CT scan with or without myelography can become extremely valuable. Again, sometimes even more valuable than an MRI.
I would agree with that. And one more on top of what he was saying, when it may be worth getting a CT maybe on top of the MRI is that the older the patients are, the more likely they can have ligament flavum that can get calcified, and sometimes there can be practically a wall of bone in your ligament. And if you're considering something like a mild, it may be not. If you know that whole ligament is kind of stuck and calcified to the dura, you may be a little more hesitant to do it because it may not work as well. So something to consider and something you will see.
Right. I think we have a few more questions. So there's one is, if there are no red flags and a patient has radicular symptoms, do you always order an MRI to evaluate before an ESI/intervention?
That's a really interesting question. I think
Yeah.
I think that it is institution dependent. I will tell you that, it's become my practice to obtain advanced imaging before any procedure. I think honestly, that is in my practice, based upon what I've seen, and I've seen a lot over the course of the years. I think that it's wise to practice that way. For our young practitioners who are listening, there are several of us, I think, on the call tonight who have done expert evaluations, legal evaluations in the course of our lifetimes, and being able to understand what you're looking at can keep you out of trouble when you do procedures, because the people who do not know what they're looking at are often the ones that land on my desk or Rene's desk or Amir's desk or Matthew's desk.
Thank you. And I think there's, let's say, the last question coming up is actually in the chat box, and it's getting asked for any resources we can recommend or textbooks, how to learn, interpret imaging for pain medicine fellows. So my approach would be, there are some standards, you can read standard literature or even radiology literature. I would say overall, you will probably not have the time and the breath to do that. So I think the very first approach is to look at all the imaging studies of your patients. When you evaluate them, looking what it is, discuss it with your faculty and go step by step. And I think the initial, when you're still learning on in the early phase, the fellowship just started, is having sort of a stepwise approach. When you look at an imaging study, if it is an MRI or just a normal X-ray, you know how you're going to look at things, and then you're going to go A, B, C, D, E, and see what is your interpretation of the study. What can you offer, or do you think you need more diagnostic studies? Those are my few cents. I'll be happy to have my colleagues weighing in, but I think it's learning by doing.
Yeah, I would agree with Dr. Przkora that every MRI is an example to learn or an opportunity. So I would always say, don't read the read initially. Look at it yourself, and then you can read the read afterwards to kind of see what you missed, see what you caught. Some radiologists will give you a lot of information, some maybe a bit less. But I would guess a huge portion of all of our education kind of comes from that strategy.
Yeah, Matthew, I mean, that's really the point. Rene, thank you for your input as well. I'm gonna add to that by saying that one thing that I believe that our learners need to do is understand three-dimensional anatomy really well before they read three-dimensional anatomy. And by that I mean draw and look and draw and look. So I mean, look, that's what I did when I was a resident and a fellow. I would draw a lumbar vertebral body from a coronal slice, from an axial slice, from a sagittal slice, and then I would do it over and over and over again. And once you understand the intricacies of the anatomy, I think you'll start to appreciate MRIs and CTs a little bit more. I went one step further where I did my fellowship, as part of my curriculum to actually understand the physical fundamentals of MRI and CT. And I think that once you understand the things that you're looking at those granular levels, meaning at understanding the physical principles, the mechanical physical principles of those of MRI and of CT and of ultrasound, and then add to that your three-dimensional spatial ability, I think you start to really begin to understand, what you're looking at. And all of us work with extremely bright and talented radiologists, but there are some things that our field understands sometimes a little bit differently than radiologists. I have not known many radiologists to comment on small facet effusions, okay, and how that may relate to a spondylolisthesis. Though that's been published, right? I don't know of many who comment on paraspinal atrophy. I don't know many who evaluate, small or moderate-sized facet cysts, and if the cyst has a calcific rim or a non-calcific rim, right? Those are things that you learn over time. And just like Matthew said a moment ago, learning by seeing, and Rene, mentioned earlier, learning by doing. These are the things that I think we have to do to elevate ourselves.
Right. I think that was a good final word for our tonight's webcast. And again, on behalf of Asra Pain Medicine and the APPD, I'd like to thank you, the audience, for staying on, and of course our speakers for participation in today's webcast. And we'll be back on Tuesday, October 3rd, and we'll be focusing on opiates. Again, a very valuable tool in our toolbox, but we have to do it right. So our webcast on October 3rd will be opiates. Indication, getting on, staying on, getting off. I hope we see you back then. And thank you, and have a very pleasant evening.